Hello, hello. So, Dr. Fatin, you gonna join us? Okay. So, because thanks for Indonesian team for your volunteer presenting the case. So, we have to wait for 1 more minute. We will start on time at 12 in my local time, but in your local time it's gonna be 1 p.m. So you have to unmute yourself. Okay. Uh, so we have only
Hi,
1 hour. So hello, hello.
hi, good afternoon, Prof. Tarsak.
Good
I'm
afternoon.
Rizky.
Uh, selamat datang. Selamat
Thank
datang.
you.
So I gonna open the discussion. So good afternoon and good evening, colleagues. Belated Happy Chinese Lunar New Year. So I'm Professor Thalengsat Kanchanabut, Chair of the ISN OSCA Regional Board. It's my great pleasure again to welcome you to today ISN OSEA Case-Based CPC. Thank you for joining us from across the region and beyond. Today's case is titled 30-year-old man with diabetes and nephrotic vein proteinuria and hematuria. The case will be presented by Dr. Dosmer. I'm not quite sure that I gonna pronounce you the correct the correct name or not. Olo, you try. Olon Simamata from Hassan Sadikin General Hospital, Bandung, Indonesia, under the supervision of Dr. Licky and Higa, right? And Dr. Alita Yanti Seti Sampi. So I'm not quite sure if apologize if I mispronounce. So as always, we encourage this to be an interactive and collegial session. Please feel free to raise your hand or post your questions in the chat box. Kindly to introduce yourself and indicate where you are joining from. With that, let us begin. Dr. Dosmer, the floor is yours. Thank you so much. So maybe you will have to pronounce your name first. I'm not quite sure that I mispronounced or not.
Yeah.
Good afternoon, Prof, Doctor, and everyone. Thank you very much for the opportunity to present one case GN here from our institution. My name is Dosmer Olwan Simarmata, and I am second year nephrology fellow at Hasan Sadikin General Hospital in Bandung, Indonesia. Today I will present an interesting case titled A 30-year-old man with diabetes, proteinuria, and hematuria. Before we dive into this CPC session, I'd like to share a bit about my home city, Bandung, often called the Paris of Java. It's nestled in a valley surrounded by lush volcanic mountains. People love Bandung for its cool, refreshing air and its vibrant blend of Dutch colonial architecture and modern creativity. It's a city where nature and urban life meet beautifully. These photos are some of tourist destinations in Bandung. Okay, next to our patient identity. The patient is Mr. FRS, a 30-year-old male, single and self-employed. He presents with progressive generalized edema beginning approximately 4 months before admission. He had a history of T2DM diagnosed in 2019 and recently diagnosed hypertension. Glycemic control has been poor with irregular follow-up and suboptimal adherence to prescribed therapy. 8 months prior to admission, the patient developed epigastric pain associated with nausea and vomiting without hematemesis or melena. During this period, he reported recurrent muscle weakness and persistent paresthesia in both hands and feet. He was noted to have uncontrolled hypertension and recurrent hypokalemia. There was no history of oliguria. Persistent proteinuria and hematuria were documented with dysmorphic RBCs on urine microscopy. In October 2024, he was admitted with ECI superimposed on CKD attributed to DKD. During the admission, he had hyponatremia, hypokalemia, hypocalcemia, and hypomagnesemia interpreted as tubulointerstitial involvement related to DKD. He was also diagnosed with mild acute cholecystitis and moderate dehydration secondary to gastrointestinal losses. Over the preceding 2 months, he had recurrent hospitalization for similar complaint, particularly persistent hypokalemia. And over the past 4 months, he developed progressive generalized edema. The patient had T2 diabetes mellitus since 2019. From 2019 till 2022, he received no treatment. Between 2022 till 2023, he was treated with basal bolus insulin for approximately 1 year. In early 2024, he self-initiated metformin and subsequently was lost to follow-up. He was also newly diagnosed hypertension, and there was no history of tuberculosis, asthma, allergy, hepatitis, or known autoimmune disease. No prior baseline serum creatinine, urinalysis, or endoscopy data are available. Regarding the social history, the patient is self-employed and there was no documented history of tobacco use, alcohol abuse, or illicit drug exposure. And family history is clinically significant. When his father had hypertension and heart failure and passed away in 2019 without a history of diabetes mellitus. His mother had diabetes mellitus and died in 2009. Importantly, his brother developed kidney failure and is currently on maintenance hemodialysis 3 times per week following a 2-year history of progressive bilateral lower extremity edema without seeking medical treatment before starting dialysis. And his sister has a history of an ovarian cyst without diabetes mellitus. On physical examination, the patient was conscious and appeared moderately ill. His vital signs showed blood pressure of 165/90, heart rate of 90, respiratory rate of 20 breaths per minute, and oxygen saturation of 98% on room air. His body mass index was 27.4, indicating overweight status. Head and neck examination showed failed conjunctiva, indicating anemia. Core and pulmo are unremarkable. The abdomen was distended with shifting dullness, suggesting ascites. The liver was palpable 2 centimeters below the costal margin. He had scrotal edema and bilateral pitting edema in both lower extremity. Let me highlight the key laboratory finding. His hemoglobin was 9.8 grams per deciliter, indicating anemia. His glucose was very high at 353 milligrams per deciliter with A1C of 9.8%, showing poor glycemic control. His kidney function showed creatinine of 1.82 milligrams per deciliter with an estimated GFR of 51 indicating CKD stage 3A. Electrolyte showed abnormalities with mild hyponatremia, severe hypokalemia, hypocalcemia, and hypomagnesemia. His albumin was low at 2.42 grams per deciliter, suggesting nephrotic syndrome. The urinalysis showed happy proteinuria 4+4 and hematuria +3, with 53.5 red blood cells per microliter. Most importantly, the 24-hour urine protein was 7,423 milligrams per day. That's more than 7 grams, confirming nephrotic range proteinuria. The urine sodium was very high at 454.6 millimoles per day, while urine potassium was low at 61.4, suggesting renal tubular dysfunction. Serologic tests for hepatitis B, hepatitis C, and HIV were negative. Antibody was positive at a titer of 1/100 with a speckle pattern, while anti-double-stranded DNA was negative. C3 and C4 normal, and aldosterone-renin ratio test for secondary hypertension screen was within normal limit. On chest radiograph, no cardiomegaly, no pulmonary infiltrate, abdominal ultrasonography with mild hepatomegaly, both kidney normal in size with preserved corticomedullary differentiation and normal echogenicity. This slide shows the cumulative urinalysis result over 1 year. Proteinuria remained persistently at +4 throughout all measurements, indicating ongoing severe glomerular injury. More importantly, microscopic hematuria was consistently present across multiple time points with fluctuating erythrocyte counts. Nitrite and leukocyte esterase were persistently negative, suggesting that hematuria was not related to urinary tract infection. Looking at the laboratory trends over 1 year is very informative. Hemoglobin show a progressive decline from 11.4 to as low as 7.2 grams per deciliter despite transfusion. Creatinine progressively increased from 1.44 to 2.73 milligrams per deciliter, showing worsening kidney function. Albumin remained persistently low, ranging from 1.73 to 2.59 grams per deciliter. Most concerning, the urine protein to creatinine ratio increased from 7,423 to nearly 12,000 milligrams per gram, showing worsening proteinuria. Okay, I stop this report, and maybe we will discuss about this patient. Does the presentation align with typical diabetic kidney disease?
Thank you, Dr. Thank you, Dr. Dorfman. Oh, sorry. Okay. 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 Thank you, Dr. Donmer. So anyone want to ask any question about the patient clinical, or want to volunteer to raise the problem list for the case? Oh, you have the question. That's good. That's the presentation aligned with the typical diabetic kidney disease, but you already answered that. It's not typical, right? Okay. Anyone want to volunteer? Otherwise, I gonna select from the portal. So anyone from Malaysia or Malaya or from Thailand, Philippines?
I'm Dr. Sarit from Chulalongkorn University. I would like to ask like some question like I couldn't catch up like the level
Maybe
of our
some
renin and aldosterone.
someone maybe many people maybe come late. So it's a 30 years old man called diabetic kidney disease and presented with nephrotic vein proteinuria with hypovolemia and edema in the setting of relative short diabetes duration, diagnosis 2019 and young age. Ask any question or ask the patient clinical more. Otherwise, I will ask my, okay, Dr. Chan, please. Thank you for volunteer.
Hi, I'm Ching from Malaysia. I just want to ask, was these patients referred to the ophthalmology to check for any diabetic eye diseases?
Sorry, Dr. Chan. I mean, because
Just want
I cannot
to,
hear you.
yeah,
Okay.
just want to ask, was the patients referred to check for any diabetic eye diseases, diabetic retinopathy?
Okay. Get Dr. Dosma, do you have any answer for that? Diabetic retinopathy or diabetic foot or any micro and macrovascular complication of diabetes? Dr. Risky, you can also
Sorry,
moderate the case
sorry,
as well.
doctor.
It was negative. We consulted for endoscopy and we were looking for diabetic retinopathy, but we couldn't find it.
Okay. No diabetic retinopathy. Thank you.
Thank you for your
Anyone want to
question, Chief.
ask more?
I'm Dr. Sarit from Chulalongkorn University. I would like to ask like about the cause of kidney failure of his brother.
There, he's asking the same question. Okay.
Dr. Risky, you have to unmute yourself.
Yeah, maybe Dr. Rosmer will answer first. Yes, uh, if it's too long, maybe I will answer for him. So the brothers actually got end-stage kidney disease, but when the brothers refers to us, it was late, so we cannot do biopsy beforehand for for his brother cases. But he present also with the nephrotic syndrome, I think, from the history from the brothers.
Okay, unknown, probably
I,
unknown
I
or
think also
not.
Dr. Suryati also asking the same question in the chat.
Okay. I post to my chat. Where is your chat, Surita?
Dr. Suryati, I think ask in the chat box, Prof.
It's
Tarsat.
actually Dr. Sunita asking.
Oh,
I cannot, yeah.
And
Oh,
she's
Surita,
using
I
my
must.
Zoom.
Okay,
We are
okay.
here together.
hi.
Hello, everyone.
Hi. Hello.
So, Surita, what your question?
It was the same question, Golf, wanting to know a little bit more about the brother because it sounded as though he had probably nephrotic
The same
syndrome.
question.
Yeah, same question.
Thank you. Okay. Anyone want to raise a problem for the case after already we have enough the information now? Dr. Salit, because you're fellow, want to challenge yourself?
Okay, I'm Dr. Sarit, the second year fellowship of nephrology at King Chulalongkorn University. So the problem list is this patient is like a 30-year-old male. He has like the first problem list is like he has like a evidence of proteinuria and glomerular hematuria like for 8 months, and followed by the clinical of progressive generalized edema with ascites and loose part edema and hypertension like for 4 months. And the second problem, this is like he also has like a tubulopathy with the hypokalemia, hypomagnesemia, and metabolic alkalosis with the normal ARR. And the third problem list is like his underlying disease of poor control DM, which he was diagnosed like 8 years ago, and the hypertension as well. And the fourth problem list is like the family history of like the kidney failure and nephrotic syndrome. So as from like the problem list, like I think like the clinical the main problem of this patient is like the glomerular disease, because like we have like a evidence of glomerular hematuria and also the dysmorphic red blood cell inside his UA. So his problem is like the clinical syndrome is like a nephritis with nephrotic red proteinuria. So the clinical syndrome of nephrotic syndrome, and also like the tubulopathy. So the cause of his disease, like, so it can be like from the immune complex, for example, like the IgA nephropathy, because like he has a normal complement system, but and also like the and other cause, it may be like the genetic disease, because like his brother like also has the same symptom as him, like the nephrotic syndrome. And the tubulopathy, I don't know, like it can be from like the DN, and also like the secondary cause of like the tubulopathy. So I think like this patient is not
from the first,
the representation of DN, and we can have to evaluate the other cause.
Salit, do you hear me?
Oh yeah, yes.
For the first problem, is it typical for DKD or not?
Oh, okay. I have to answer this question first. Like, so this is not the typical presentation of DKD, because like he has the clinical of nephrotic syndrome and also like the active urinary sediment, because we found the evidence of the dysmorphic red blood cell inside his urine exam. So it's not the typical presentation, but the DN.
Thank you. And for the second one, you also raised electrolyte abnormality, right? Hypo-K, hypomagnesemia, metabolic alkalosis. Do you think is it related to the DKD as well?
So this is not the typical presentation of the DKD as well. Yeah.
So what is the typical electrolyte abnormality for diabetes?
The hyperkalemia because of the RTA type 4.
Okay, type 4 RTA, right? Okay, Dr. Risky, go ahead. Maybe I should not conduct too much.
It's okay, Prof. Golf. Thank you for connecting this. Actually, this patient, yes, correct with as what your fellow said earlier, that this is not a typical presentation for diabetic nephropathy. We usually found that diabetic nephropathy found with high proteinuria usually, but in this patient, it's very high. within nephrotic range proteinuria, and also we found persistent hematuria, and also we found some electrolyte abnormalities leading to making us thinking about, is it tubulopathy in diabetic kidney disease. Tubulopathy in diabetic kidney disease is also some common presentation, but that's what's make us confused, because he has a brothers and also got renal failure, and also with a family history of cardiovascular disease with hypertension and diabetic. So that makes broaden our differential diagnosis into maybe it's genetic or maybe it's related to the cardiorenal metabolic syndrome. Dr. Dosmer, maybe want to ask something? Want to add something? Or maybe from the floor?
Good afternoon. Excuse me, I'm Elizabeth from FKUI Jakarta. I would like to ask a little bit question about these patients. I haven't heard that before. Can you re-explain that to me, Dr. Dosmer? What is about the EGFR of the patients? And have the patient already been biopsy, kidney biopsy? Thank you so much.
Maybe before Dr. Dosmer will answer, maybe I will ask Dr. Elizabeth, do you think we should biopsy this patient?
Yes, I think if we meet the patients, it's about proteinuria more than 500, and persistent hematuria, we should think, and this is only this also the patient is also in the young patients about 30 years old, so we should think about the other maybe GN or IgA nephropathy. So maybe we can get any options for this patient.
What you have in mind? What kind of glomerular disease maybe this patient had?
Maybe IgA nephropathy, or if there is a glomerulonephritis or the others, or anything which can make the persistent hematuria and dysmorphic red blood cell for these patients.
Okay, thank you. Maybe any other opinion? Or we want to continue, Prof. Goff?
We should go ahead because it's a long story of the case.
Okay, please, Dr. Dasmer, you can continue. Yes,
Because
maybe.
it's a quite complicated cases.
Maybe the next question. Okay, Dr. Dasmer, you can continue your slide.
Okay, doctor. What alternative or additional diagnosis should be considered?
I think it's already clear, Prof. Goff, that some of the fellow mentioned maybe something about genetics problems or IgA. Any other opinion? Any
Okay.
FSGS or maybe anything else?
Any fellow want to challenge yourself again before we perform kidney biopsy? What is on your mind? Normal complement and negative serology beside NA positive 100, right? As I recall, 100 and negative double strand DNA. And maybe from Malaysia, I see a big group from Malaysia. From Philippines, in oh, I see Orisa is coming, right? Of Vietnam, Anyone from Vietnam want to? What is on your mind? Okay, anyone?
Yeah. So good
Oh,
afternoon, good morning. I am Dr. Hai An from Vietnam, and thank you so much for very interesting case. I think we would like to have also a very suspicious to have the some genetic disorders, including the tubulopathy, and also we'd like to have also, if you do have the electrophoresis of proteinuria and the protein in the blood.
Dr. Dosma, do you have
I'm sorry.
Dr.
Do
Hai
you
An,
hear
you
me?
asking about the protein electrophoresis, right?
Electrophoresis of blood serum protein and the protein in urine protein.
Okay. SPEP and
Thank you.
USPEP and also light chain, free light chain. Dr. Dosma, do you have that?
Okay, Prof. In this session, we do not examine. We don't examine the urinary protein electrophoresis and serum protein electrophoresis because this patient too young to suffer like plasma disorder like multiple myeloma or PDN-MID.
Because the signal is not quite clear, so I'm not quite sure. Is it negative, right?
Yeah. We didn't check it, Prof. Gov, for the
Okay.
plasmapheresis.
Check it.
We didn't check it. Yes.
Okay. Any fellow from Thailand, Malaysia?
Here from Malaysia.
Okay. Go ahead, please.
Hi. I'm Ferry from HKL Malaysia. So, given the history of herbal supplement there, so thinking of aristolochic acid nephropathy also in this patient, as the patient has a progressive failure and anemia on top of it.
Okay. They asked about herbal drug remedy. I guess no, right? No. So we're gonna do kidney biopsy. So what is on your mind? The first, second, and third differential diagnosis. Do you think it's a typical DKD by kidney biopsy, or do you think that they have anything on top, like IgA? Someone already mentioned that, or what else? But because the patient have a severe electrolyte imbalance, so do you think that does the patient have tuberous interstitial disease thing? Otherwise, Dr. Salit, what is on your mind? Dr. Salit.
The first thing that I think that this patient has the DKD, but maybe like the IgA on top, but the Eli imbalance cannot be explained by all of the diseases that I mentioned. So at first, like I think about like the cause of the tubular interstitial involvement. So I don't know, like it can be involved like in the, like some autoimmune disease, like the secondary TI lesion, maybe like the joking or like other thing, but like his complement is normal, so it kind of contrasts a bit like about the cause.
Thank you.
And can I know like
Dr.
the
Doss
result of the serum aldosterone and renin of the patient, because like you only show like the ARR ratio.
but it's normal, right? It's normal.
Okay.
As I recall, it's a 10.
So if we're gonna approach like from the hypocamate alkalo and the hypertension, I don't know it is a cause from like the gum disease or just the disease itself of hypocamate alkalo. So I don't know like the picture of the patient can be like legitimate like lesion that secondary from autoimmune disease, maybe like Jochen or like autosystemic disease that can cause the glomerular involvement as well. But like it's kind of weird in this patient because like the autoimmune disease, if it has like the glomerular involvement, usually like the complement will be low. So maybe like this patient had like some kind of genetic disease that present with the MPGN pattern with the tubular involvement as well. So we need like the biopsy to confirm the pathology first.
By electrolyte abnormality, when you see severe hypokalemia and hypomagnesemia, metabolic alkalosis, what is on your mind? Most commonly, differential.
At first, we have to take the history about the diuretic because maybe like he used to
Yeah,
control
the
his
diuretics.
hypertension.
Does the patient take any medication or diuretics as he asking? Probably, Dr. Liski, can you respond for that?
Because of the patient is edema, the patient is given some diuretics for the edema. Because within 4 months the patient got edema, so we give the patient diuretic. I think maybe we can
It's a
jump
loop
to the
diuretics, right?
yeah. So we can jump to the pathology, I think.
Okay, good. Yeah, great. We already have 24 minutes left.
Okay. Please,
Okay.
Dr. Rosman, can you continue your slide? Dr. Hai An, maybe can you mute yourself first because maybe it's unmuted. Okay, thank you. Prof. Gov, do you want to ask the fellow?
Okay. Many friends from Malaysia. Oh, Dr. Salit again. Or anyone want to volunteer to read the slide? I think it should not too complicated. Okay, because the time limited. Dr. Salit, okay, please.
Okay, from the first section that you show, like we can see the striking presentation that like this patient kidney biopsy show the marked tubular atrophy and also the tubule loss of like back to back, and also like there is like some cell infiltrate inside the interstitium, maybe like the mononuclear cells. And from this slide, like I cannot see the vessel and the gum.
Can we continue, Prof. Gov, or you want to explain more?
Yeah. Next, please, because I think he should read the whole slide before
Okay.
make
Maybe
impression.
maybe you should say beforehand what's the staining of this. Maybe this is HNE or PAS.
Oh, I'm sorry, this one is the HNE.
Yeah, that's correct. He said SME.
Can you change to the next slide?
Go ahead, let's start it.
Okay, this biopsy like show the one glom, and I can see like there is like some. This is a H&E staining, and there is like some mesenteric expansion with some eosinophilic content, and also like there is like some endocap, and the GBM is kind of a bit thickening, but we have to confirm by the PAS staining.
So what is the glomerular pattern for this section? This is the diabetic glomerulopathy, or is a MPGN pattern? What is the pattern?
I think it's like the MPGN pattern, because I can see the endocapillary involvement, and also like the membrane is a bit thickening. So it is not the typical of DKD.
MPGN pattern with lobulation, right? Okay, MPGN pattern with lobulation.
Can you shift to the next one, please? ต้องบอกให้เขาเปลี่ยน So this section of the grom, like the left one, we can see like the marked endocapillary hypercellularity, and also a bit of the membrane thickening, maybe the same MPGN pattern as well. And the cell that infiltrate the endocapillary is like the mononuclear cell. And we can see like the tubular structure is marked atrophy as well, and some mononuclear cell infiltrate inside the interstitium.
You see the cyanosis of afferent arteriole and also perigrom fibrosis or something like that.
Oh yes, like this is a picture of the end as well, but there is like some MPGN pattern on top of it.
Okay. Can you tell us what kind of cell infiltration in the gland from the previous slide?
I think it is a it's a mononuclear cell mixed with like some PMN as well.
Mononuclear cell predominate, right? But you see neutrophil.
Yeah, I see the neutrophil as well.
From previous slide. Okay, go ahead. Next slide, please.
So this gum like is a collapsed
You need to-
gum and with
Yeah.
the polygonal fibrosis, and there is the vessel on the left side is marked intimal hyalinosis. This can cause by the hypertension and the DN as well.
Okay. Next slide, please, because the time is quite limited.
And
Next
next
slide,
slide, please.
Yeah. Lot of instances of inflammation, right? Can you tell
This is
us
the mark.
what kind of cell, that infiltrate? And then you see tubular is tubular atrophy, right? And what cell is pleomorphic cell or mononuclear cell or what kind of cell?
Is a pleomorphic cell is a mix of like the mononuclear cell and neutrophil inside the interstitium.
Maybe we have to go back to Dr.
Dr. Anglita.
Dr.
Dr. Anglita.
Angita, right? Angita, to review the slide because of the time constraint.
Yeah. Thank you, Professor Goff, and thank you, Professor and doctors attending this meeting. Thank you for the opportunity also, Dr. Rizky and colleagues from the nephrology. This case is kind like rare, at least for us. In here, we have performed the HNA immunostain and also some histochemical like the PES, mesenterichrome, and also silver methenamine. And finally, we perform the immunofluorescence. Next, please. As mentioned by the doctors before, it's correct. Thank you, doctor. You already mentioned some of the abnormality that we can appreciate it from the biopsy slide. But I think one very important that maybe you missed, we can see clearly that there are many chemostin Wilson nodule as the pathognomonic features of the diabetic nephropathy. Also, some hypercellularity at the epithelial of the capsule, Bowman capsule. And then next, please. And that's correct that the glomeruli is infiltrated by many inflammatory cells, consists of the mononuclear and also neutrophil or perimorphonuclear, including at the interstitial tissue as well. There are many inflammatory cells surrounding the glomeruli and also the tubuli. And from here, we can see clearly there is a global sclerosis. Next, please. I think the past, please. Yeah. And this is the past result. Many abnormality we can appreciate it from these features, starting from the vessel. That's correct, doctor. There are sclerosis, and then the glomeruli itself, many sclerosis over there, and also the Bowman capsule. We can see the thickening of it, and the tubuli also. We can appreciate the membrane basal is thickening, and also atrophic of its tubular itself, with obvious of the interstitial fibrosis. Next, please. Yeah, this is just the enlargement features of the previous that I mentioned. Next, please. Yes, next, please. I think just the same. We go to the mesenterichrome, please. The blue one, Dr. Dosmir. Yeah. Yeah, from here, we can see clearly the global sclerosis and also some interstitial fibrosis. Next, please. Yeah. Yeah, you can appreciate it clearly from here. Next. Also here. Next. Yeah, with the higher magnification, we can see that the some of the glomeruli is atrophy or collapsing, and the intimal fibrosis of the vessel is obvious, and also the thickening of the capsule Bowman as well. Next, please. Next, please. Yeah, this is the silver methenamine. We are very sorry that the contrast of the pars is not that great at this moment, but we can appreciate the same feature here as mentioned previously. Next, please. Yeah, this is actually the same features as I mentioned in the trichrome and also in the pars PAS staining. Yeah, next, please. Yeah, the glomeruli, as mentioned before, there were hypercellular of the endothelial and also the mesangial cells. Next, please. Yeah, here we comes finally at the immunofluorescence result that are a bit shocking us. The immunoglobulin for the G antibody is positive. The next. The IgA is even higher positivity. Next, please. IgM less, but we can see that the sclerotic is seen clearly in here. The antibody is deposited. Next, please. C3 is also positive, but not as nice as the IgA and IgG. Next, please. Yeah, also for C1q is positive. Next, please. And the fibrinogen, we can see that the vascular is not really positive, but the surrounding is positive. We can see just slightly positive at the capillary. Next, please. The kappa was negative. And lastly, the lambda, please. Oh, no. We don't have any lambda, I think.
Maybe it's negative, I
Yeah,
think.
the
Dr. Amit.
lambda is negative as well. Sorry for our miss. Yeah, thank you, Professor Gov and Dr. Rizky. Back to you.
Thank you, Dr. Angita, right? Angita. Right.
Yes, my pleasure. Thank you.
So, I'm not sure, Dr. Rizky, do you want to conclude the pathology finding?
Yes, maybe we can appreciate from the light microscopy, we see some mesangial hypercellularity with the immunofluorescence with the codominant of IgA. So we conclude that this is a mix with the diabetic kidney disease with the IgA nephropathy. And also we find some neutrophil infiltration with the tubular interstitial disease. Maybe Dr. Dosmer will continue the presentation first. Please, Dr. Dosmer. So this is interesting cases where we found diabetic kidney disease, as we know that this is common disease that causes chronic kidney disease worldwide. But in this patient, we decide to perform a biopsy. Maybe Dr. Dosmer can continue the presentation.
Okay, doctor.
So while wait, not announcement.
All discussion.
You please move closer to the microphone because we cannot hear you well.
Okay, Prof, are clear? Are my sound clear?
Yeah, better. Okay.
Thank you, Prof. After we discuss about this patient, we now will discuss when we should perform kidney biopsy in diabetic patient. Okay, Literature shows that non-diabetic kidney disease is common in diabetic patients. From that table, the study showed that glomerulopathy spectrum for 52% of non-diabetic kidney disease cases, with IgA nephropathy being the most common, representing 17 cases in one study. Importantly, multivariate analysis has identified key predictors. The presence of diabetic retinopathy is highly predictive of diabetic nephropathy, with an odds ratio of 26.68. However, microhematuria, defined as 10 or more red blood cells per field, is an independent factor strongly predicting non-diabetic kidney disease, with an odds ratio of 0.032. This means that when hematuria is present, non-diabetic kidney disease is much more likely than pure diabetic kidney disease. And multiple studies from different countries consistently show that hematuria is significantly more common in non-diabetic kidney disease compared to diabetic nephropathy. This table summarizes clinical features that raise suspicion of non-diabetic kidney disease or NKD in patients with diabetes and may indicate the need for kidney biopsy. We can see in the slide. And in the slide, we can see minor recommendation and major recommendation for doing kidney biopsy. This condition may raise suspicion for non-diabetic kidney disease and should prompt careful clinical evaluation. Microalbuminuria occurring without diabetic retinopathy may suggest an alternative renal pathology. A rapid increase in proteinuria is atypical for classical diabetic nephropathy progression. Increasing proteinuria in patients with a short duration of diabetes, especially less than 5 years, should also raise concern. Optimal and precise centers, this finding do not mandate biopsy but warrant closer assessment. And major recommendations are in clinical features strongly support consideration of kidney biopsy, like suspicion of systemic disease, presence of kidney injury, hematuria, which is uncommon in typical diabetic nephropathy, nephrotic syndrome, or significant proteinuria occurring early in diabetes, particularly in the absence of diabetic retinopathy. In this situation, biopsy becomes important to exclude non-diabetic kidney disease. But we are weighing the advantages from disadvantages of biopsy. The advantages of biopsy include establishing an accurate diagnosis and guiding appropriate treatment, providing prognostic information, improving our understanding of the natural history of diabetic nephropathy, allowing better classification of patients for targeted clinical trials. However, biopsy is not without limitation. Higher procedural risk in elderly patients, multiple comorbidities, increasing complication risk, use of antiplatelet or anticoagulant therapy, technical challenges in obese patients, and additional healthcare costs. Diabetic kidney disease is one of the most common etiologies of end-stage kidney disease. DKD develops in 30% of patients with type 2 DM, diabetes mellitus, and 40% with type 2 DM. About 30 to 40% of patients with T2DM have renal involvement after 10 years of evolution. Kidney biopsies are performed less frequently in patients with diabetes. Kidney biopsy reveals one of 3 possibilities: diabetic nephropathy, pathological diagnosis of DKD, non-diabetic kidney disease, and DM plus NDKD or mixed form. The prevalence of NDKD has been reported to be variable, which is between 23% till 73%. The table summarizes the histopathological evaluation of diabetic kidney disease based on the Renal Pathology Society classification. It assesses kidney injury in three main compartments: glomerular lesion. This component evaluates the severity of glomerular damage caused by diabetes, including glomerular basement membrane thickening, class 1, mesangial expansion, class 2, nodular sclerosis with Timo-Still Wilson lesion, class 3, and global glomerulosclerosis, class 4.
Sorry, Dr. Dosmer, maybe due to the time limit, maybe we can just move to the last slide.
So the conclusion in this topic situation today
Before we ending the case, can I comment a little bit?
Yes, please, Dr. Prof.
From the histology, it seems there is a quite prominent neutrophil infiltration within the glomerular tuft and also in the interstitial, suggesting acute inflammatory component rather than pure chronic diabetic chain or IgA nephropathy. And on immunofluorescence, the smear linear pattern of IgG and IgA may representative non-specific entrapment, which is common seen in the decay. So, however, what stands out is the C3 and C1q deposit cannula with some linear accentuation. So that raises the possibility of superimposed process, perhaps post-step or post-infectious IgA deposit on top of the maybe post-step.
Yeah, thank you, Professor.
Yes, Professor Goff. Yeah, maybe
Okay.
we'll also consider about that, about the PIGN in this patient also.
Yeah. I think EM can help us because if you see the subepithelial hump,
Yes,
electron microscope gonna be help us. Yeah,
Yes.
subepithelial hump. Yeah, would be support the post-infectious process. But yeah, if it's negative, it probably IgA nephropathy. So otherwise,
Yes.
we can like wait and see.
Yeah, that's also our hope in the future. Maybe we will do the EM if our center can do a EM in the future.
And also for electrolyte abnormality, because the patient have take the diuretics. So after stop, so the patient still have hypo-K, hypomag or not?
The patient is lost to follow up, unfortunately.
Oh, okay,
Yes.
okay.
Yes, but we will make sure whether, yeah, that will explain the electrolyte abnormalities in this patient.
But anyhow, it's very, very beautiful cases. Very beautiful case. Anyone want to ask or make a final comments?
Good afternoon, Professor Golf. This is Afiatin. Hello, everyone.
Hello, nice to meet you, Fiatin. Thank you
Nice to
for
meet you too.
your coordinating.
Yeah. We try our best to prepare this presentation, and I'm sorry for my wrong. I think I can choose GN and PD, so I choose the PD for the GN for now. Okay, thank you, Professor Golf, and all of the college who have already in this session. I just want to highlight this patient because this is the patient came to our polyclinic, and there was some point that we missed about the condition of the underlying disease of his chronic kidney disease. At the first, he was the patient is have to take care of their family, so he one who has to work and who has to take care of his sibling who has underwent on HD. That's why we have this patient has was lost to follow up many times, even after we did the biopsy. But I want to highlight that if we have a patient with a long story about the diabetes mellitus, as in this patient, but if we found that there is some discrepancies between the clinical feature and the laboratory finding. For example, in this patient, the problem the problem is about the electrolyte imbalance, and we made some laboratory measurement that this caused by the tubulopathy. But at that time, there was no edema at all, and the patient has no complaint of oliguria. Even the proteinuria is around 7,000 milligram per day. So that's why this patient is a bit, we missed some points because at that time he was do the treatment with that kind of laboratory finding, but we didn't think about another etiology or another underlying kidney disease for his chronic kidney disease condition. Fortunately, at I think the second or third visit, we decided to do the biopsy because there is a lot of discrepancy between the clinical profile and the laboratory finding. We have an electrolyte imbalance, heavy proteinuria without edema, and of course there were some hematuria, and the hematuria is the persistent. And fortunately, Dr. Anglita found that this patient have also the the feature of the IgA nephropathy. So we decided to make a diagnosis that this diabetic kidney disease superimposed with the IgA nephropathy. But until now, we try to find what is the cause of the IgA nephropathy, because I think this is the secondary. This patient has some lymphadenopathy. We did the biopsy also, but there is nothing. It's only the unspecific lymphadenopathy. And again, we lost to follow up this patient, but Dr. Dosmer has made the phone call 2 days or 3 days ago. He's fine. He has still have edema, and we asked him to come to our clinic again to take some medication. That's all, Professor Goff. Thank you for our fruitful discussion. So the take home message from me is, if we have to if we have some discrepancies, so we have to make sure what is the problem of our patient. Thank you very much. Good afternoon.
Thank you, Dr. Fiatin, Dr. Dosma, Liski, and also Angita for your wonderful presentation. And also the record of today's session will upload to the YouTube shortly, and we will circulate the links in the chat box. And a brief announcement: we will skip March and resume our next ISN OSEA case. Going to be PD case discussion in May, probably on May 26th at the usual time. Please mark your calendar. Once again, thanks for your participation and continued commitment to advancing kidney education across our regions. Last but not least, please turn on your camera very short for capture our group photo, and have a wonderful day and evening ahead. And thank you so much for everyone. See you soon on March. Oh no, on April. We skip March.
Thank you, Prof. Golf.